Okay, here we go. Continuing on to part 2 of respiratory. We were talking about gases and how they dissolve. And so this is a picture of oxygen dissolving. You have it in the air of this beaker and it's dissolving into water. And if you were to calculate what happens at equilibrium, where the pressures are equal, in other words, there's no more oxygen is going to become dissolved or not a whole lot of oxygen is going to come out of solution. It's kind of at equilibrium. At that equilibrium, what is that pressure? And it's measured, if this were 100 millimeters of mercury, that's an assumption, let's say it's at 100 millimeters of mercury, then the pressure in the air here is 5.2 millimoles per liter. It's not something you're going to memorize. I just want you to see the comparison of the numbers. When you come down into here, it's that same partial pressure, 100 millimeters of mercury in the water. Only the number of molecules is diminished, and it's only about 0.5 millimoles per liter. Okay, so that's equilibrium. Not a whole lot dissolving when it's oxygen. Enough to transport some of the oxygen, but definitely not enough for you to be able to distribute all that to your cells. Let's compare and look at it with CO2. So let's start out with the same partial pressure. You start out with 100 millimeters of mercury, okay? And that's what it is in this atmosphere inside my beaker. How much of it dissolves? Well, as a comparison, 5.2 millimoles per liter in the air portion and about 3 millimoles per liter. And you can see in this diagram, it's really good. A lot more of those little balls, right, of CO2 have dissolved than in that picture there. So 5 there, let's say, and a whole lot more here. So that is a difference in solubility of carbon dioxide in a liquid. Super important concept. Now, pressure gradients are going to drive that exchange, right? Carbon dioxide exiting from the body, oxygen coming into the body and coming into the blood and coming into the tissues. So we want to compare the oxygen pressure in the alveoli, in the capillaries of the lung, the capillaries that are just surrounding those alveoli that's, that is just receiving that oxygen, and then the actual cells that's the true destination, right, is where you need this oxygen to be, in the cells. So these drawings are really helpful because it shows part 1, the alveoli in purple. Part 2, this is circulation with its arterial and venous blood. And part 3 here are the cells. So look at these numbers. These numbers are more important. You have 100 millimeters of mercury arriving at the alveoli. Remember I said it was about 160 that was happening at sea level, atmospheric. That was the pressure that you were obtaining. Yes, when it comes into your nose. But as it travels down, there's a drop in pressure, and by the time it reaches the alveoli, it's at about 100. So this is sea level, 100 millimeters of mercury are coming in. This, then, is going to be quite a lot higher than the partial pressure of oxygen in venous blood because you've used up that oxygen, correct? So it's higher. If it's higher, it's going to go from the higher pressure to the lower pressure. Until when? Until it's equal. Until those two are at about 100. So this is arterial now. I've put it into what was venous. It's become arterial because it's full. Full, and it's going to reach a cell. A cell that's undergoing metabolism and is using up oxygen is needing more. So its value is going to be lower than the 100, and it's going to be able to receive that pressure of oxygen. So till when? Well, till it equalizes. What does it equalize at? Well, at about 40, right? So in it comes, we've used it up, and now the pressure here in the blood has dropped considerably from 100 to about 40. But then it's going to go back up into the lung and load up again. So we're good with that. In this section, we've shown how we've distributed that dissolved oxygen to the cells, and then off the venous system goes to pick it up again. So let's look at CO2 now. In the alveoli, it's at about 40 millimeters of mercury. In the venous blood that's trying to get rid of some of this, it's at 46 right now. So if 46 is higher than 40, it's going to be able to cross that membrane, come into the alveoli, and you exhale out that carbon dioxide. which leaves the arterial blood at about a PCO2 of about 40. 40, 40, 40. It's coming close to a cell. The cell has been metabolizing. It's full of CO2. 46 is higher than 40. It'll be able to dump it into that circulation. We carry it now in venous blood, and if 46 is higher than 40, we dump it into the alveoli, and out we breathe it. So that's kind of the cycling of, it needs to be higher in order to move to a lower pressure. That's the only way that these gases are going to move. Once equalized, that's it. Those are potential values, sort of what are the real values. I wanted to show you a chart of this. So arterial goes about a pressure of oxygen anywhere from about 85 to 100 in the arterial. And in the venous, it is at around 40. The carbon dioxide is around 40, 35 to 45. And then in the venous, 46. This is important too. What's the pH? So pH has to be dead on, right? 7.38 to 7.42. We're very fussy about our pH. So those are the values that we're looking for to see that everything is functioning in the respiratory system. These are good diagrams that show, oh look, alveoli, 100, I'm pumping it into blood that's at about 100 also. And this is showing if this tissue is low in oxygen, then this oxygen at 100 will be able to cross quite readily. The respiratory membrane is a huge surface area of millions of these alveolar sacs. Very thin. It's got to be very thin because if not, none of this transport is going to happen, correct? So it's got to be very thin, and that diffusion distance has to be very tiny. So this is, you have one cell layer that comes from the alveolus, one cell layer that's on the capillaries. So the capillary, it's only has, this oxygen has to cross one barrier, which is the lining of the actual alveolus, and one lining, which is the capillary layer. And then from then it's going to go to a cell that's one layer again. Some pathologies that I want to show you. What happens when the system fails? Hypoxia, too little oxygen in the blood into the brain. It can result from low oxygen in the alveoli. Not enough is coming in for lots of different reasons. Oxygen exchange in the capillaries is low. Something's happening that the capillaries are not able to receive that. Or the transport, something's wrong with the transport. So there's a series of slides here that talk about, with these little small diagrams showing you, this is normal. You have an alveolus and you have the capillary and it should pass quite easily. And this is an emphysema, fibrosis, pulmonary edema, asthma. Let's see if I can get to all of these. In emphysema, you have the destruction of the alveoli. So instead of having lots of little balls with lots of surface area, you've destroyed that surface area, and that surface area is diminished. If it's diminished, then the partial pressure here is going to be lower, and it's going to be blue here because you weren't able to transport enough of that oxygen. So emphysema comes from years and years of aggression to the alveoli. It could be smoke, it could be coal, it could be asbestos, it could be anything that you've been inhaling consistently and has been damaging the walls of those little grape-like structures. What about fibrotic lung disease? This could also happen after the same conditions that I just told you. It's thickened alveolar membrane. It's thickened because it's trying to protect itself. It's like, oh my gosh, all this coal is coming into my lungs. Let me just make a layer that's thicker, not allowing that to come in. So now this oxygen could be normal coming in, but it can't cross that fibrosis that's happened in the lung. Therefore, pH low. Pulmonary edema, fluid in the interstitial space. That was this space here. So you've increased the distance, the diffusion distance, hard to cross, hard to reach the other side. PO2, low. Asthma. Look, this little diagram looks different, right? It's this now. Look, let's compare with the previous one. The entryway. It's these airways that are constricted. The bronchioles are constricted and not enough air is coming in. Nice way to illustrate that, sort of easier. This is something that comes up a lot in respiratory physiology, and that is, what is the difference between a disease that is obstructive and one that is restrictive? So in an obstructive disease, the airways are constricted. So the anatomy of all of it there looks fine. There's no damage to it, but it's constricted, it's narrowed. So if you've narrowed it, it's hard to get air in there. That's asthma, it's bronchitis, it's emphysema. It's so hard to get it in because you've damaged the airways. That is different from a restrictive disorder where you have actual damage to tissue. So for example, a tumor, and it's enlarged there in the lung, and it's just not, you're not able to get air to that whole area that has the tumor. So your vital capacity is reduced. Your vital capacity is when you take a big inhale and then a huge exhale. It's that total volume of air that you can inhale. So that vital capacity is reduced. Notice that it wasn't reduced in obstructive, because if you give the asthma patient enough time, they will take forever, but they fill, and they'll still have a good vital capacity. They're able to do it, but with time. The restrictive disease, you are unable to do it, right? This is fibrosis, tumors, any sort of definite damage to the tissue itself. Obstructive and restrictive. Very confusing because the words sound the same, right? An obstruction and a restriction sound the same. So you have to find a way of differentiating those two. I'm going to stop right there, and we'll have just part 3 as the last part of this section. Thank you guys. Bye.